Oregon Health and Science University presents a resource for health science educators. Profiles of health science professionals with disabilities. Nurses with physical disabilities. Candy Moore, RN, MSN. Ms. Moore has been a practicing RN for over 26 years. She is currently a faculty member in the nursing program at Elgin Community College in Illinois. Ms. Moore received her BSN in 1975 and her master's degree in nursing in 1981, both from Loyola University, Chicago. Her clinical specialty was in medical surgical nursing with an emphasis in gerontology. Additionally, she holds a certification in holistic nursing. Ms. Moore was born with only one hand. She has been an acute care nurse, staff nurse, and department manager, as well as an educator. Sonia Perduta Fulginiti, RN, MS, CRRN. Ms. Perduta Fulginiti is a registered nurse and clinical nurse specialist in neurology. After initial training in nursing, Ms. Perduta Fulginiti was in a car accident that left her with a spinal cord injury at the T12-L1 area. She is a paraplegic with no sensation or mobility from the hips down. After her accident, Ms. Perduta Fulginiti completed her BSN at Fitchburg State College, Massachusetts, in 1980, and then her MS in nursing at the University of California, San Francisco in 1984. After more than 20 years of direct care nursing, Ms. Perduta Fulginiti is currently an independent disability consultant and trainer.
I have nothing but positive things to say about the nursing faculty. I never felt different. I was never treated differently than I felt. Looking now at this stage back, I can see that there were some evaluation pieces that were different than other students. For instance, good example to bring that point is that when we were in our labor and delivery rotation, there was a baby ready to be born, and the nursing instructor said to me, "Candy, I want you to scrub. I want you to put on sterile garb and assist the physician with standing next to him, handing him things and helping him suture the episiotomy." I thought, wow, what a chance. No one else gets to do that. What I really realize now is she wanted to test my ability to do that. But at the time, I was thrilled. I was thrilled to get an extra chance at something. I never thought of myself, this is the truth, I never thought of myself as a nurse with a disability until the last year and a half. Now, did I know I didn't have a left hand? Well, of course. Did I know I was different? Well, of course. So to me, I always lived this way, but now I have formulated this into thought a little bit more. It's just a difference. I tie my shoe. I tie it differently than you do. It ends up looking the same. As a nurse, I give injections. My instructor helped me figure out how to do this. So we figured out one way to do it, because when a nurse gives an injection, an intramuscular injection, with one hand you're supposed to pull the skin taut, and with your other hand you handle the syringe. And it was hard for me to do that. And we figured out a way to actually do that. So the next day, I learned how to give a Z-Track injection, and I thought, well, this is really easy, it works, and I'll just use this for all my injections. So the accommodation there, the adaptation was just, I do something that is commonplace all the time anyway.
Clinical-wise now, choosing my clinical programs was kind of easy, I guess. I knew I wanted to do the rehab portion, and I knew I wanted to focus mainly in spinal cord injury, because I had a feeling that me being spinal cord injured would help other people with spinal cord injuries. So I decided to do my practicum at Boston University Hospital on the spinal cord injury unit, and I was assigned patients that I could handle. That was part of the accommodations that they made for me, is that I wouldn't get high-level quads that I couldn't reach or that I couldn't suction, as in if they were vented, it was hard for me to reach trached patients in order to suction them. to reach the controls on the vents themselves. So I was pretty much given patients that were acute but may have been paras, low paras, high paras, and lower level quadriplegics, and those in varying stages of their acuteness. So it worked out pretty well, and everyone was astounded with what I could do from chair level. I could turn people in bed, again, depending upon their level of function. I could get people dressed. I could catheterize people. I could do bowel programs. One low-level quad and I actually helped each other get him out of bed. We did it as a collaborative task with someone standing by as a spot. But it worked out that I could get him out of bed using a sliding board. Boston University Hospital was a great experience for me because it only gave me more self-confidence and made me feel really, really sure that I could still function as a nurse. And my other goal of wondering if I would be a good role model to patients came across pretty loud and clear too, especially with the men. The men really liked outdoing me. So if I could do it, they had to do it better than I could. So anyone saw me do something and they were learning how to do it, they'd ask me, show me how, and then once I'd show them, they in turn would do it and keep going at it until they did it. It was, oh, if she can do it, then I can do it, and so it got done. And a lot of times patients confided in me a little bit more, I think, than they did in other nurses because they felt like I knew where they were coming from and I had similar problems or issues that were going on in my life at the same time, and we could sit and chit-chat. Trying to find the accessible place in an amphitheater was really a hard thing because, you know, there's two different floors there. You have to figure out, do you have to come in the amphitheater on the lower level? Do you come in the amphitheater on the upper level? And then where do you sit? I always found I was always segregated from everybody else because I always had to sit way in the front or way in the back. There was no desk for me, nowhere for me to write. You know, I didn't have anyone to chit-chat with. If I felt like chit-chatting, if I had a little question about something, I had to wait till after class, hope that the professor would come up by me, and then I could ask the question. Or, you know, you'd see my hand from way back there, or I could ask another student. Trying to get from class to classrooms, you know, I always had to, again, go the circuitous routes. Only certain people, those who became friends with me, would travel those long distances with me. So those were issues, and again I said the bladder is really, really important. There needs to be accessible toilets on every floor, and a lot of colleges even to this day only have one accessible bathroom in one building, or not even in the same building. And to expect students to kind of, you know, leave a building or leave a floor to go to use the restroom facilities, I think is totally unacceptable and inhuman. One of the accommodations I had to make was how to figure out how to do the practical aspects of bedside nursing. And one of the things was for, say, sterile dressing changes. What I would do is I would, the problem that I came up with is that I was trying to figure out how, when I would go to the sink and wash my hands, how I would then stay clean when I knew I would have to touch my wheelchair to get and go across a hospital room to the hospital bed. I knew my hands would be, you know, all contaminated again. So what I made a point of was every morning before I started work, I came with a short lab coat, was what I wore, and I would stuff the pockets full of gloves, or I would carry a backpack or put a bag on the back of my chair and keep supplies in there so I knew they were in there. And then I would wash my hands at the sink, I would put on a pair of latex gloves, wheel across the room with the latex gloves on, and then I would position my wheelchair, get all ready, and not touch anything bedside, but then I would take the gloves off, discard them, and then my hands would be clean, and then I would then pursue sterile technique to do dressing changes. Some of the other issues that may be with the dressing change may be leaning over to get to the patient. I would always have to make sure, you know, prior to becoming sterile, making sure the high-low bed, the bed was up high enough so I didn't have to lean over too far and maybe lose balance, because that could be a problem if all of a sudden I'm leaning into a sterile area of a wound and I lose my balance. I didn't want to fall into the patient and contaminate him. Sometimes if things were pretty hairy that I might think that would happen, I might even put a belt on to keep myself secure in my chair. So there were accommodations that I had to learn and make, and no one else had done them and could give me the pointers, so I had to think about how to do them myself. There really wasn't a lot I could not do, or that maybe that I attempted to do that I could not do. I guess I knew my limitations real well. I knew what I could lift. I knew how far I could lean forward without falling over. I knew when I should put a belt on for more trunk support. I just knew that. I guess the main thing was I never wanted to jeopardize a patient's health and safety, and I knew that if it got to that point, then I would have to leave bedside nursing and do something else. And my forte really was at the bedside. I did well there.
If I had been asked the question 3 years ago, where is nursing in terms of nurses with disabilities or student nurses with disabilities, I'd have answered that kind of question very differently. 3 years ago, I would have said, this is not an issue. I'm here. I didn't have much trouble getting here. I now see that picture so differently. So for me personally, I'm absolutely shocked, just blown away, shocked by the response of my peers, of state boards of nursing, position papers being written about students with disabilities. I'm absolutely shocked, and that's why I'm here, because it's not okay with me. It's not okay that that is my profession saying that. And then there's also the concept of professional conscience. I think because we have and every profession will have their code of ethics, because nursing has the American Nurses Association Code of Ethics, black and white, it's been there many years now. Every nurse in every nursing school, one way or another, is taught that. But one of the points in the code is that I will protect patient safety. I will protect the public safety, I think is how it's worded. Okay, I'll do that, with a disability or not. I accept that part of my code of ethics. Another piece of the code, and again paraphrasing, is that I will be aware of my competency level. And I'll use that, I'll know my abilities, and I'll know when to ask for help. I'll know when to ask for consultation. Okay, I will. Disability or not, every nurse will do that. And so I think when we lose sight of that in our profession, if we lose sight that we have a code of ethics and think that a nurse with a disability or a nursing student with a disability won't rely on that same code, we've drifted. We've drifted from professionalism.
And I would never choose a field in nursing that would put a patient in jeopardy of that, or I would ever want to do that. So it takes a lot of introspection to know what you can do, what you can't do, and whether the job you want will allow you to work within that realm. And I think that's the key to most of it, is you have to know what you can and cannot do, what accommodations will work, what accommodations won't work, or what accommodations are totally unacceptable. I know here in the Worcester area, if you can't lift 50 pounds, then they won't let you into a nursing program here. I could not lift 50 pounds, but I think I'm a great nurse. So if they wouldn't allow me into that program, then they would lose the other skills that I would bring into that, which I think is what nursing really needs to look at now.
We tend to evaluate the affective domain, the cognitive domain, and then the psychomotor domain. You know, we've kind of decided those are our 3 domains for teaching and evaluation. And when we're evaluating psychomotor, we tend to want 100%. We, the faculty, want 100%. You can do it or you can't do it. You must do all the skills in your nursing lab or however you're taught. If you can't give the injection, then you can't be a nurse. If you can't insert the tube, you can't be a nurse, because we have these skills on our list of good, got to know these things, and have to be able to do them. So it's this 100% thing, 100% evaluation measure. Now think about when we give an exam, whether that's an oral exam, a written exam, a multiple choice exam, an essay exam, all the ways that we test the cognitive, pure cognitive, no psychomotor aspect here. There is never a requirement that everyone pass at 100%. Every school will have their policy that says this percent is passing, 80%, whatever it is, 70%, 85%. And so listen to what we're saying there. We're saying it's okay not to know some. It's okay to have gaps in your knowledge. We release you to the real live world with gaps in your knowledge. You do not have to pass your NCLEX exam at 100%. No one does. Now, someone could, but in reality, no one will know every little teeny piece of knowledge. And we still release them as a safe nurse. The student nurse in a wheelchair who will not be able to transfer this patient, just no matter what I do, no matter what the nursing faculty, teach them all the different ways to do it, all the aids you can use for transferring, in terms of equipment. Some nursing faculty will say, well, then you cannot be here. You are gone. You cannot be a nurse, because it's that 100% evaluation pass rate for psychomotor skills. And I look at that as, you can't do it. We accept you can't do it. That is of no essence to nursing. Now, do I need to still evaluate her? Yes. Does she get a waiver on this? Not really. She must show me that she has the knowledge. She must list out for me all the steps. She must list out for me all the principles of body mechanics and patient safety. She must be able to direct the nursing assistants in making this transfer. She must be able to teach the wife, caretaker for this patient, all the safety tips involved, and observe her doing it and guide her through that process. I can evaluate her as a faculty member that way. Whether she ever in life will transfer a patient or not, it doesn't matter. I'm concerned about her knowledge there. Will that student, who then becomes the nurse because I have released her into the world of the workplace, will she be a safe nurse? Well, the essential function list will guide whether she, in her wildest dreams, will ever need to make a patient transfer in that position, that role, nursing position she's in.
Nursing students who come in with disabilities, I mean, when you think of the benefits, when I think back and when I thought about that nurse when I was applying for that job, and she told me that there was no benefit that I could do for her patients, right there I knew that nurse was really small-minded and narrow-minded, and actually was probably a poor nurse to be on that unit, because she would promote dependence and pity and all of that in her patients.
It teaches the person that I'll figure this out. One experience I had was last week. I was at clinical with my beginning nursing student. It was her last week of clinical, 6th week, and she was irrigating a nasogastric tube using the air bolus method. So she had to use a stethoscope, hold the stethoscope on the right place on the abdomen, and use the syringe to push in the air, and hold the syringe together with the NG tube so it wouldn't, spray all over. And she's looking at me like, now, had she practiced this in the lab? Yes. Had she verified 100% she could do this in the lab? Yes. So now we're at the real life bedside, and she's looking at me like, I need another hand. And I looked at her and I said, Jill, I can do this with one hand, so I'm confident you will figure out how to manage this with two hands. And she started laughing. She goes, I guess so. So it taught her that I can do this. It's just my first time really doing it, but I'll learn how to do this. With patients, like I'm thinking back to my home health days where I would be working with older adults who are needing to learn how to give themselves insulin injections, and their vision is not perfect and their hearing is not perfect and their arthritic fingers don't move perfectly anymore. And they look at me and they see me do it and they know they can do it.
To change attitudes, people have to see you, and they have to know. Like, for me to change the attitudes of the physicians and the nurses that I work with all those years, they had to see me in there working as a nurse, wiping someone's, butt, emptying a bedpan, changing someone, getting them out of bed, feeding someone. They saw me doing those things, said, wow, okay, she's a nurse and she does just what we do. So that was an attitude changing kind of thing. But what happens when you can't get into those environments, if there's no access, if there's no universal access? Then you can't get in there and you can't have people see that you're a, Joe Blow just like everybody else. So where does that put people with disabilities? It puts us in this nebulous place that we have no power, and it's trying to become empowered to change the system, and it's a brutally hard system to change. Brutally hard. The medical profession, I think, promulgates this whole disability stereotype and mythology about being sick, about being dependent, about being pitied. I think medicine promotes that because medicine, when you think about it, controls the lives of most people with disabilities. That I can't even get a wheelchair without a doctor's prescription. I mean, that sounds absurd when you think about it, because I couldn't go anywhere without a wheelchair. But you have to have a doctor's prescription to get a wheelchair. He decides the kind you get.
Specifically in terms of disability, I cannot imagine a disability of any way, shape, or form closing a door to a person who wants to be a nurse. She will find her place. And nursing faculty need to remember that we don't know what the place might be, because we don't know what will be in 10 years. We think we have ideas, of course, but might that nurse create another whole arena to work in based on her nursing knowledge because she has that disability? Things that I can't even imagine. And that's the benefit of diversity in the profession.
Health Sciences Faculty Education Project, a resource for health science educators. Project staff: Project Director Joanne Sowers, PhD. Project Coordinator Martha R. Smith. Dissemination Coordinator Lisa Ferris, M.Ed. Project Administrative Assistant Tina Campbell. Additional support provided by Clark Hochstetler, M.A. Narrator Z. Boone. For project information, please contact Martha R. Smith, Center on Self-Determination, Oregon Health and Science University, 3608 Southeast Powell Boulevard, Portland, Oregon 97202. Telephone 503-232-9154, extension 131. Email smitmart@ohsu.edu. These videotapes were partially supported by grant PR/3P333A900-51 from the Department of Education, Office of Post-Secondary Education. Copyright 2002 by Joanne Sowers and Martha R. Smith. All rights reserved. No part of this material may be reproduced, stored in a retrieval system, or transmitted in any form or by any means without prior consent of the copyright owners. Oregon Health and Science University presents a resource for health science educators. Profiles of health science professionals with disabilities. A nurse with a hearing loss.